Thank you all for having me. Apologies for not being there in person. I grew up in Ann Arbor. I love it deeply. It makes me so sad to not be there. Everyone go to good restaurants and Zingerman's and have a Gemini rocks the house for me. Those are also two really, really hard presentations to follow. Those were awesome. And in addition to the ones earlier today, have just been a phenomenal sort of brain bend in terms of thinking about all the ways in which COVID changed things. So I'm going to talk specifically about one sort of slice of this puzzle. That's mixed metaphors right there. I'm looking specifically at Medicare Advantage versus traditional Medicare during COVID-19. So this is our investigator team. RJ is in the room, I think. Anything good he can take credit for, anything bad I take responsibility for. We have a great group across a few different institutions that's been working on this. And what I'm going to share today is preliminary. So this is work that we sort of have initial data for, but we're digging into the details. So we'll look forward to feedback. And if folks have thoughts about future directions, we're very interested in that because, as I said, this part of our work is still in early phases. So as folks have already mentioned, and as you all know, there was, of course, an increase in excess mortality in 2020 from COVID, both the direct mortality of COVID and also the indirect mortality associated with changes in care for other conditions. And we know that much of this burden was borne by Medicare beneficiaries, those who are older and typically more medically complex. So though certainly we saw infection across a wide range of ages and medical complexities, most of the mortality did occur in people with pre-existing medical conditions who were older, et cetera. The longer-term impact of COVID on health outcomes remains somewhat unclear. And so our goal is to try to untangle some of the more recent data. But wait, there are actually two separate Medicare programs. And I think probably most of the research that people are used to seeing in terms of claims is on fee-for-service Medicare, which we'd consider sort of traditional Medicare. There's another program in Medicare called Medicare Advantage. And that's Medicare managed care, where the government is a structure and you go purchase a private plan. Now, the popularity of Medicare Advantage has been growing, so about 20% in the late aughts, and now rising over 50% in most recent data. And Medicare Advantage is growing in popularity for a few reasons, but the biggie is because it actually has additional benefits like vision and dental that traditional Medicare doesn't have, and it has markedly better protection against out-of-pocket expenses, at least for those who don't purchase supplemental, what are called Medigap plans. So it's been growing particularly in minority populations and those living in poverty who tend to value those additional protections and benefits to a greater degree. Proponents of Medicare Advantage really argue that it provides important support, coordination, basically additional value. And opponents basically say the government's paying too much and getting nothing in return. So COVID was an opportunity to think about that. The idea that folks on Medicare Advantage might have had some additional resiliency because of COVID or during COVID, because of the higher use of capitated payment and the provision of non-clinical services through Medicare Advantage and private plans could mean that there was sort of additional support available that wasn't reliant on the fee-for-service billing that dropped off a cliff during COVID. So our goals were to determine whether there were similar increases in mortality among traditional Medicare versus Medicare Advantage beneficiaries, and those would be labeled as either TM or FFS, depending on if I remembered to be consistent, and MA. And then to determine whether any increases, if present, differed by rurality or social vulnerability, and I'll show the rurality results today. We're going to focus, at least for some of the analytics after 2020, where COVID itself was less of an issue, but sort of the care disruptions remain just because everything changed so much in 2020. We're looking a little bit more for what we can learn about current state from some of those later patterns. So we use the Virtual Research Data Center to examine utilization from January 2018 to December 2022. We have fee-for-service data through 2023, but Medicare Advantage is on a little bit more of a delay. It was an enormous amount of work to get Medicare Advantage data up and running. So some of it is in this. Some of the details around encounter data and whatnot, we're still working through with RJ and an analyst in our group function who are really doing great work on that, but we'll show the mortality stuff today. So we considered January 2018 to December 2019 pre-COVID. We sort of ignore 2020 for at least the regressions, and then we look at January 2021 to December 22 as sort of later COVID. We look at utilization at the county month level. Some of these graphs will look similar to other things we've seen today. And we're looking for comparisons between fee-for-service and MA and between metropolitan, micropolitan, and non-CBSA or rural areas within each group. We use a log normal Poisson model that adjusts for county level demographics. So very briefly on our sample, we had 510,550,103 beneficiary months in Medicare Advantage and 830,852,385 beneficiary months in fee-for-service. On average, Medicare Advantage beneficiaries are more likely female, Black, and Hispanic, which is, again, following national trends and enrollment in this program, less likely to be duly enrolled in Medicaid as a marker of poverty, and less likely to live in rural or micropolitan areas compared to urban. And there's just not as much availability of private plans in rural areas in this country. So here you can see the raw numbers for mortality for fee-for-service versus Medicare Advantage over the study period. So fee-for-service is in blue, Medicare Advantage is in orange, and you can see at least visually that prior to the pandemic, there was a notable and fairly consistent gap between the two, with Medicare Advantage having lower mortality. They followed the same patterns throughout the study period in terms of the peaks and falls that were associated with COVID. And then there's always peaks in the winter months from flu and other infectious diseases. And you can see, if you squint a little bit, that in the sort of 2022 range, it looks like those lines are getting a little bit closer together. And if we look at the same graph, but stratified by rurality, a few other patterns emerge. So in this case, the blue solid line is fee-for-service urban. The blue dashed line is Medicare Advantage urban. So the paired rurality urbanicity groups are in the same color. So blue and blue, orange and orange are micropolitan, and gray are rural. And so you can see a few things. There is a gap in each of the sort of urban versus rural situations between MA and fee-for-service, particularly in the pre-period. Those lines get a little bit closer in the post-period, but really where we see the highest mortality throughout is in micropolitan and rural fee-for-service, and to some degree, micropolitan and rural Medicare Advantage, though, again, some of those shifts are a little bit different through the sort of later period in 2021, 2022. I can get this to advance. Here we go. When we put some numbers on that, you can see in pre-COVID, MA did indeed have lower mortality than post-COVID. And again, this is adjusting for other basic demographics at the county level. So some of these look a little bit different than the raw data because the age distribution, for example, is different between urban and rural areas. But you can see that both MA and traditional Medicare had increased mortality in what we'd consider that later COVID period, which is pretty markedly higher, right, on the order of 16 to 18% higher, relatively speaking. And the increase in mortality was statistically significantly greater in MA, though sort of unclear clinical significance. I mean, in these sort of big populations, that small percent does amount to a lot of people, but it is, tenfold lower than the difference in terms of COVID versus non. And if we look, breaking it down by rurality and by the MA versus fee-for-service, on the left in MA and on the right fee-for-service, in both cases, again, you can see that micropolitan and rural areas had higher mortality pre-COVID, that everyone went up quite a bit in this late COVID timeframe from sort of 16 to 19% or 15 to 19%. And then the differences between micropolitan and rural versus urban in terms of the change associated with COVID were pretty small, measurably higher, at least for 3 out of the 4 circumstances there, but again, pale in comparison to COVID itself. So in summary, mortality remained elevated in 2021 and 2022 in the Medicare program to a pretty marked degree. You know, we had thought there might be a healthy survivor effect, maybe lower mortality. That has certainly not turned out to be the case, and it doesn't in 2023 either. The effects were sizable, and the differences by payer were small relative to the COVID effect, but MA did have a slightly greater increase in mortality, which was contrary to our hypothesis. Micropolitan and rural had slightly greater increases in the fee-for-service group, and micropolitan had an increase in mortality in the MA group alone. I think the interesting part comes next, which is to say, what is the etiology of this persistently elevated risk of death? Is it COVID itself? Probably some, but there wasn't that much death from COVID sort of as we go across the time frame, right? We see a lot more of the other types of death also being relevant. So post-COVID sequela of sort of the inflammatory milieu created by this disease, or changes in care-seeking behaviors in persistent ways that lead people to seek care later than they perhaps ought for some acute conditions. So that's some of the important things we don't know, which leads me to future directions, which is to dig into the why. So again, COVID versus non-COVID, acute versus chronic, site of death. I can tell you preliminarily that death increased out of hospital, in hospice, and in hospital. So it wasn't that only one site of death increased, but certainly digging into that a little bit more is important. And then while we've broken this down by county characteristics, we also want to understand differences by patient type. So severe disease, which we've done to some degree, and again, preliminarily see the same relative increase in all groups of severity, though obviously the absolute differences are different. But other characteristics, including demographics, frailty, baseline access to care, or having access to primary care, for example. So lots of things still to do. As I said, this is preliminary, but we've been surprised at how persistent it is, and sort of think it's an important place to dig into, and hope we can lend some insight into the broader context that COVID has sort of left us with in more recent times. So with that, I'll stop and say thank you, particularly to the NINR for their support of this work. It's been a pleasure to work with them, and I look forward to continuing the relationship. So thanks so much.